There's, any kind of drainage, what color the drainage, the odor of wounds. Those are all the things that we kind of pay attention to during wounds. In general, we do a lot of wound care that involves cleaning, debriding, getting rid of this necrotic tissue to then, enter into these ideas of edema control and desensitizing. So we teach the patients a lot of self-wound care as well. But again, early intervention and assessing these wounds to compare to norms. Oftentimes I'll take photos. I mean, photos are so easy now. Everybody's got a phone to take a photo on. So, people are often measuring it themselves when they come in for wound care with me. They can say, hey, can I take a picture today? Yeah, because look what it was like last week. And they've got it right there. So it's a great tool to use, even better than our descriptors. So, scar status. There's different degrees of scar. And again, there's no great way to measure. There's certain color board scar rating scales out there. But in general, scars have a thickness component to it. They have an adhesion component to them. They have a hypersensitivity and a pain component to them. And they have an elasticity component to them. So I'll try to either describe scarring with those kinds of terms and then try to, again, get people to pay attention to what their scars feel like, look like, and move like, because that's what they're going to get involved with directly in managing those scars. So scar tissue is really a big factor that can really get in the way of people's recovery too, because it's painful. It has poor circulation. It can be thick and robust, so it can adhere to tissues underlying it, and that can get in the way of a lot of recovery. It can create joint stiffness and create muscle tendon adhesions, and that limits movement. So scarring is a big problem. So we definitely address scarring as it goes. Soft tissue swelling. Obviously, there's a swollen hand. And this is a typical hand that I would see after a person sprains his wrist even. After a wrist fracture, the cast has been put on, they've been in it for a while, the cast is killing them, they get it taken off, but this is what it looks like. So what the heck do you do with this? Well, leaving it alone is probably not going to get it any different by putting a new cast on. So we'll get involved early to start working on some edema control measures with this while the immobilization phase is still continuing. So I will make some of these braces. I will make braces to act as a removable cast so people can get the stability and protection. They can sleep with it. They can do their daily things with it to some degree, but it doesn't have to be this non-removable cast where we can't then affect that tissue that needs to be treated, which is the swelling, the hypersensitivity, the pain. So the soft tissue is a big component as well. That again can be addressed very early, even before injuries are healed.
So are those moldable then, or
these are? I'll pass these around right now. These are. There's different thicknesses of these. We call these thermoplastics. So these are custom molded. I can make any shape for any design, for any type of size of hand. There's some finger ones that we'll pass around. So anything really that you can imagine a hand needs for either immobilization or protection, we can manufacture that and make that out of these thermoplastics.
I can speak to how well this particular facet of therapy works because I had a removable one myself that I used. And while I was at work, I would work religiously during the day, but at night I took it off to give my arm a little rest.
Oh, yeah.
And just, I wouldn't be doing this sort of thing. I'd be holding like this, but just going like this with my hand.
You can massage. You can wash.
Yeah.
You can wash your
being able to feel
the benefits of that on the neurovascular system are tremendous. Just to be able to get stimulus and touch on there without movement. So there are some examples, like David was saying, about custom types of things that are removable but there for protection if you need them. Example: wrist fracture, finger fracture, joint dislocation.
Yeah.
So those are some of the assessment tools that we use. Then we get into some of the dexterity testing. So we've got the Jepson hand function sword. We've got different manipulation tests. A lot of these things have standardized research behind them. I don't use them so much for the standardized research, but often I'll use them as therapy tools to just give people this idea of, here's what we're going to do. Let's time you on this one component today and see 2 weeks later if it's getting better. So for instance, on the one with on your right side there with the pegs, people grab that little dowel and flip it over. So they're requiring some dexterity, but also this rotation. So for someone like David, again, I'll use him as an example again. That might be a test that I do early on to see how fast he can do that task. And then maybe 3 weeks later, 4 weeks later, I'll measure it again to give him some feedback. Hey, it's getting better, you're getting faster. So here's some progress. Because sometimes the motion might not be getting better, but the speed and dexterity might be getting better, but that's still progress. So we try to define progress in different ways, not just motion and strength, but function and ability. Some of the work-related testing, getting into, again, either functional capacity evaluation purposes, but also work simulation for rehab purposes. There's nothing like strengthening and conditioning people based on what they need to do. It's one thing to lift a weight, it's one thing to squeeze a bit of exercise putty, but it's a whole other thing when we can get someone doing what they are going to need to do, whether it's an athlete, again, whether it's a mom who just had a baby, or whether it's an injured worker who pours concrete all day. Functional strengthening and conditioning is really more effective and more valuable to people than, again, the unilateral types of motion that we're typically associated with, for instance, in a gym setting. So functional activities is really what we try to focus on and get people doing a lot. Again, even as home exercise programs. Some of the testing that we'll do to define, do you have tendonitis, do you have arthritis? Some of the evaluative procedures that we do. The one on the left side is a test for de Quervain's tendonitis, where you actually put the thumb in the palm, have people reach like I am, and then bend it. And if they're painful, they'll point to this area of pain, and we know that's the positive test. That's called Finkelstein's test for de Quervain's tendonitis. So it's these are some of the provocative maneuvers that we'll do to evaluate people to see whether or not they have a problem going on where they do. Oftentimes I'll get people referred to, they have pain, but there's no clear diagnosis. So I'm trying to figure out, okay, what is the problem here that's creating your pain? You have tendonitis. On the other slide there, it's a test where I can, kind of hold onto the thumb metacarpal and grind that CMC joint to test people whether they've got arthritis at that joint, for instance. So there's different provocative maneuvers that we can identify the tissue involved, whether it's bony, whether it's ligamentous, whether it's tendinous. To identify the tissue is really important because then I know what I'm treating. So if I can provoke a problem or provoke the pain that people are coming in with, which sounds horrible to do, but it tells me then what the tissue is involved that then I can start treating. So I'm not doing it just for fun.
Do you ever get hit?
Occasionally I sit sideways a lot, so I've learned to do that over the years for sure. And I'm good at ducking.
No, and what I like about all the things you're saying too is it's that it's the education of movement, because like when I did my physical therapy too, I mean there was things I had stiffness and pain, so I was doing stretches and things at home that I thought should help it, but I was actually doing the wrong kind of stretches.
Sure.
So it was that education that helped me understand why what I was doing was harming it,
Yes,
and why
absolutely.
you would tell me actually relieved and made sense. And it was the opposite of what I
so
thought
valuable.
I should do.
An example that I see commonly is, I'll see someone that's, been dealing with their own injury, like a wrist fracture. It's a common thing. So people say, well, I've been working on squeezing a ball, I've been working on this. And I say, okay, but I've been getting a lot of pain in my palm here, and I'm not sure what's going on there. So I look at their wrist, and they're doing fine. They've got great motion there. I give them a few ideas of what they can work on. But then when I look at their palm, I realize that what they've actually created is a trigger finger problem in their palm. So by working on themselves so hard to regain strength, in such a repetitive way, they've actually created another problem, which unchecked they would have kept creating. But just knowing that, okay, this might be what's going on. This is what might be causing it. So let's take that out of your therapy as your home program. Let's focus on this instead of just kind of, diverting people into what the proper avenues are. The knowledge is so powerful.
Yeah, that education.
It really, and in your experience, you've known that. You've noticed it.
Yeah.
So, and it really is. And that's really what I tell people is, most of what I can provide is teaching, and I can show you what to do, and then you with me can do it. But me fixing it is not really going to happen. You need to be the bigger player in this to take on what I say to keep doing it.
Do you do a fair amount of handouts?
Of home exercises and that kind of thing, absolutely. And there's a lot of varying tools that we have. One of our systems generates things as we need. We have a lot of different tools that we can generate, literally picture handouts with descriptors on them so that people can have them. And we store them electronically, so if everybody ever needs them, we've got them. We can remember what they were if they're coming back 2 months later. So definitely that's a good resource. To some degree, a lot of people that I've dealt with too, I find with some people, if they have pictures, they don't necessarily pay attention to what they're doing either, because they rely just on, okay, I got a picture there, I don't really need to remember that. But the picture can show them what they're doing, but the technique can get, for instance, overlooked or forgotten. So a lot of times I'll use the pictures, but I'll also say when I bring people back in, show me that exercise.
Yes.
I don't have your picture, but show me what it is that we were doing. Because I want to see the demonstration of it, because the technique is important as well. So, yeah. I'll keep moving along here.
Oh, I had it upside down.
Yeah, exactly. So again, we're just talking about education. Yes, exactly. Now, why does it hurt when I'm doing that? Yeah. Scar management, some of the techniques or tools that we use, massaging, teaching people how to manipulate scar tissue, basically put stress on scar tissue, can help scar tissue remodel. And again, those things can be done early in a wound recovery phase, immediately after wound closure.
Can you recover after 4 years?
Pardon?
If you have adhesion, scar adhesion,
Yes.
can you really recover it like years later?
No.
Okay.
Well, unlikely. Scar tissue, once it's taken its effect in the early phases and it turns into a chronic problem with adhesions, there's not likely a conservative way to reduce that adhesion. I tell people over time, and I've seen this with tendon adhesions as well. I've seen people where I don't think that tendon adhesion is going to get better, but people left alone over a certain amount of time, even up to a year, year and a half, your body will continue to try to reorganize that scarring for up to a year and a half. And I've seen people where we're done therapy, there's nothing more that people need to see me for. But I'll say, listen, see me in 3 months. I'm just curious to check up on you. See me in 6 months. So they come and see me, and sure enough, some of that scarring has released itself just with your body's ability to manipulate that scar tissue and remodel it over time. But somebody that's a year, year and a half is really at their plateau point and stationary point with scarring. And after that, there's probably nothing that can be done to release an adhesion other than surgical release of an adhesion. So to some degree, they can have an effect on it, but in a later response, the effects are much less. Other tools, scar massage tools, and other modalities. The one on the right is like a dry whirlpool, so occasionally we'll use that. It blows these little kind of particles around, simulates a dry whirlpool.
Sawdust.
Yeah, you've seen that.
I've done it.
Yeah, so it's one of the tools, been around forever. Not a lot of clinics have them. I think it's a useful tool. It's really good for desensitizing people with hypersensitive scars. A lot of my amputation patients really would benefit from that desensitizing. It's a heat tool as well, so it can warm up. The idea is to simulate a dry whirlpool. So that's one of the tools that are out there. Different techniques, massage, compression wrapping, compression gloves, again, edema management tools, soft tissue mobilization, various types of techniques of massage, motion exercises. The one on the far right, active motion, getting stretching. The one in the middle, active motion, making a fist. The one on the left side is a technique we'll use to, after we're done some passive stretching for a stiff hand, I'll tape it. And I'll leave it there, and I'll educate people to tape it themselves and leave it there for long durations of time. The general philosophy of undoing stiffness really requires a low load of intensity over a long duration of time to elongate tissue. A lot of times people work really hard and stretch things aggressively and let go and stretch aggressively until they're in tears, and a lot of therapists will do that. The reality is we're not really affecting tissue change. We're hitting an endpoint, and what we might be doing even is creating a rebound effect, where your tissue responds to that stimulus and contracts, rather than sneaking up on it by putting a low load on it, like a taping technique or some of the splinting techniques, to put a low stretch load on it, but leaving it for 4 hours, 6 hours long. That tissue has a chance to elongate. Oftentimes what I see is the fingers get stiff like this. People can't straighten them after wrist fracture, after trauma to the hand. Straightening is a really difficult thing to do. And if you think about, well, why did my fingers get stiff? Because I broke my wrist. Well, your fingers rest like this. They don't rest like this. So when the whole hand is swollen and they're resting like this for 8 weeks, 12 weeks, they're going to be stiff. So we try to elongate them along the way by using splinting techniques, where we'll slowly, incrementally put a splint on, change fingers up, use splinting, use the taping techniques to change tissue length, to gain motion. So splinting and taping, not just for protection, but to actually gain mobility. General functional things, obviously people need to do things in life. So those are the main focuses of what we try to do. Modifying activities, modifying tools, whether it's a mouse, whether it's a pen, whether it's a drill, whether it's a hammer, whether it's a tool for washing baby bottles, whatever it might be, changing the tools to fit the hand is a lot of what we can educate people on as well, and can often be a very valuable resource, because there's only so many things that we can get some hands to do and recover to. And again, examples of joint protection types of tools out there for the arthritis patients, for the patient with a really painful hand in certain motions. The key holders, you don't have to pinch and twist something fine. Use your whole handle to twist. Little ideas like that. Doorknobs are really a bad design.
They're nasty.
Yeah, doorknobs are really horrible, so put levers on them, changing things out. But just giving people ideas of how to make things easier to do. So you're not necessarily making your hand do that thing, but you're making that thing easier for your hand to do. Taps on people's homes, too, are really difficult, sometimes the round ones.
Yeah.
So just changing them out to levers or putting levers on them, it's so much easier for people to function. So again, matching the tool or the activity to what then the condition is, to blend both things together is what we can educate people on. Different strengthening exercise like we talked about a little earlier, the traditional things, weights, therapy putties, elastic bands, there's a lot of those kinds of tools out there. Some of the machinery that's out there for work simulation. Again, work hardening, using a lot of types of things to simulate what people have to do. We're trying to really make them do what they need to do and give them the successes or show them where it's not going to be successful so they can then make appropriate recommendation. But trying to create a real environment as possible. Again, ergonomic modifications, changing how things are set up to make it easier for people. Some of the modalities, there's varying types of modalities that are electrical out there, electrical stimulation, neuromuscular stimulation, iontophoresis, ultrasound. Truthfully, a lot of those tools, the longer I've been doing this, the less and less I use a lot of those tools, because people cannot do that at home. And if they're coming to see me once a week or twice a week, if I'm doing that ultrasound for 3 minutes, what am I really doing to this person? But if I can teach them what they need to do to create the effects of what that ultrasound is doing by using heat pads and massage, I can achieve the same thing that way, and you can do it at home. So it's more valuable to me than relying on the tools that some people think can fix them, which is it's just not true. They're tools that we use to make an effect on your body to, in most cases, create either muscular activation or circulatory enhancement to then stimulate your body to heal itself. Those tools don't fix people. They stimulate your body to heal itself. But we can use a lot of other techniques manually to do the same thing. Heat modalities to me are very valuable. Hot pads, again, certain things like wax baths, that flutotherapy machine, the dry whirlpool on the right. Different heat modalities, obviously cold modalities can work for that acute inflammation, chronic inflammation sometimes. Whirlpool, splinting, which we've talked a little bit about along the ways. There's different types. Static splints that don't move. They're there to position something, hold something, whether it's to gain motion, whether if it's for protection, whether it's to immobilize. Static splints, think of them as they don't move. Varying examples, you see a thumb wrist one on the far right side, little finger ones. You'll see this one out here, and I commonly do those for mallet fingers. A lot of times people use the popsicle stick as the old treatment, right? Emery boards. Those big aluminum padded things. That by the time you put one of those on, the hand looks like a forearm, or the finger looks like a forearm. So we can custom make really low profile. And I think there's a couple of those floating around too, the little tiny ones. So the real small, I take them on, show people how to wear them, and I see them for checkups to make sure the skin isn't breaking down over time, and it's a really good way to manage that common condition called a mallet finger, for instance. Different things, the one in the middle there is a fracture protection, splint for a metacarpal fracture, the typical boxer's fracture. Different examples, finger fractures, whatever it might be. Again, protection splints that do not move, static. Static progressive. These are some of the tools that I was describing, that we put a tension on something, but then we hold that tension. So there's different types of devices. This is called a merit component, but it's kind of like the tools or the components on a guitar that tighten the strings. So you tighten it to a certain point where it applies a certain amount of pressure that's tolerable, with the idea of holding that pressure. But again, the splint doesn't move. It just moves till you get to the end, but then it stays there. So it's not applying constant tension. The tension stops when you get to the end point. So dynamic splints are different. These ones allow movement within the tension of the actual splint. So we would sometimes do these for arthritic joint replacements, sometimes with tendon repairs like you see on the left-hand side. But even those philosophies are changing a little bit too, so we don't use those as much as we once used to. Some of the dynamic where you see rubber bands being used to generate force to get certain motions. Some of the off-the-shelf stuff, there's still, some of them are very good for different conditions if they fit well. And that's the 99% of the time, unfortunately, they don't. But if they fit well, they can be very useful tools. They're soft, they're often comfortable for people. So those are sometimes tools we'll use instead of custom making something. That's really most of blasting through what we do as hand therapists. You know, I put this slide on here, that's just, you know, obviously where you can find me, but there's, depending on whatever community you're in, the organization that I refer to are the Hand Therapy Certification Commission. You can search for a hand therapist no matter what community you want to look for worldwide. So if you're ever, you know, referring someone who has been here on vacation that's going to go, you know, move back to Florida, you can look up and say, hey, there's a hand therapist right in your neighborhood. Here it is. Go call them. Here's a referral. Get down there. You can look up any hand therapist literally worldwide through that organization by geography. So you can always find a hand therapist no matter where people live, or at least, you know, in proximity to where they hopefully live. Any other questions that we haven't talked about? I've taken up a lot of your time.
How well does insurance cover?
It's definitely variable, depending on your insurance coverage, because what the insurances are really covering are not the certified hand therapist as a specialty. They're covering OT, they're covering PT. So it's really the standard, whatever the coverage might be for OT or PT services, depending what the background discipline is of that certified hand therapist. So that's a lot of the similarity of what you've probably already been dealing with people in general going to physical therapy or occupational therapy. It's very dependent on the insurance itself, whether it's covered or not. The interesting thing is, like for instance, Medicare covers occupational therapy for a certain dollar value annually. It covers a combined physical therapy and speech therapy under the same dollar value annually. But it won't pay for the cost of materials for the splints that I showed you.
Yeah.
But it'll pay for my time to make the splints. Whereas other insurances, they will pay for everything under one different billing code. So it really is variable depending on who the insurance is, on what's actually covered. And the best way to know is really just for the person to either call in to ask or check. But when they check, to know what it is that they need, so I can properly describe it to them so that they can properly get an assessment from their insurance, what it is that they're actually being recommended for. But it's variable. It really is variable. So, yeah. Any other questions, comments? That's hand therapy, and that's what I do. Yes.
Children and adults?
All age groups. Really, it's not dependent on any type of age group. Whether it's I mean, I've seen 4-month-old kids that have had syndactyly surgical revisions done to their thumbs. That I'm there to teach them, mom and dad, how to manage the scarring, the sensitivity, how to position it, educating the parents on that. So really, any age group is really, it doesn't matter. Hand injuries, hand trauma, hand surgery, whatever it is from here to here, no matter where it's been, what's been caused by, what the environment that it occurred in, what age group, it doesn't matter. We don't, you know, we'll see anybody with those types of conditions.
Could you say handless from here to here?
I usually tell people the focus of what we do, some hand therapists are really keen on, they really love treating shoulder injuries and they're really good experts at that. I find that the minute I get into shoulder problems, there's inevitably back and upper neck issues. So I don't like to say, listen, see your hand therapist for the shoulder problems, because I know there's going to be neck and postural problems associated with it. So I like for that stuff to go to the PTs. But really, when anything below the shoulder, I like to say is, you know what, that's our area of true expertise, and we can identify and manage those kinds of things with great expertise. Absolutely, absolutely. Yeah.
Thank you, Mark.
Thank you.
You're welcome. Thank you.